Good afternoon, everyone. It is my pleasure to welcome you to today's Susan G. Komen's virtual Metastatic Breast Cancer Impact Series event. My name is Gina Chicatel, and I am the Manager of Mission Education for Susan G. Komen. The programming for the MBC Impact Series is envisioned as a year-long conversation with our attendees, presenting new information and speakers each month. Today, our topic is managing neuropathy from MBC treatments, and our featured speaker is Dr. Brian Schneider with the Indiana University Simon Comprehensive Cancer Center, and our fantastic moderator is Megan Hanvey, MBC advocate and a member of Komen's MBC Steering Committee. Before we begin, Komen would like to thank our sponsors for supporting the 2025 MBC Impact Series. Thank you to our premier sponsors, AstraZeneca, Gilead, and Merck, and our signature sponsors, Daiichi Sankyo and Novartis. This series is made possible because of their generosity. One more housekeeping note. So while our speakers are talking, please feel free to post your questions in the Q&A feature in Zoom. You can find it in the lower panel with all the other tools. And we will get to as many as we can at the end of today's presentation. But please remember, our speakers are not able to provide individual medical advice, so keep your questions as general as possible. And towards the end of our program, we will drop a survey link in the chat. Your feedback is very important to us and helpful as we plan for future Impact Series events. Your surveys are how we determine what topics we will feature throughout the year. Now, we are excited you all are joining us for today's discussion. To start, I would like to introduce you to our moderator, Megan Hanvey. Megan is a positive, fun-loving, and compassionate woman who finds purpose in life by giving to others and to her family. She is married to a great man and is the mother of two amazing boys. Driven by her passion for helping others, she worked as an occupational therapist with children in San Diego for nearly 25 years. After being diagnosed with metastatic breast cancer in April of 2023, she retired to focus her time on being with those she loves, as well as continuing to give back to her community. Megan has become involved as a board member with Camp Kesem, an organization that supports children who have or had a parent with cancer. She participated in the 3-day breast cancer walk in honor of her sister, mother, and grandmother, who have all passed away from cancer. More recently, Megan became involved with Susan G. Komen as a speaker and a team leader with the More Than Pink Walk. She is honored to be a part of Komen's Metastatic Breast Cancer Steering Committee and looks forward to making a difference in the lives of those living with the disease. So Megan, welcome. I will turn it over to you.
Thank you. Good morning or afternoon, depending on where you are. I am honored to be here and looking forward to our speaker today. Personally, I have not experienced a lot of neuropathy, really only just a little bit, so I'm very grateful for that, but it could be something that comes down the line for me. But it was with great pleasure that I introduce our speaker today, Dr. Schneider. Dr. Schneider is the Vera Bradley Professor of Oncology at the Indiana University Simon Comprehensive Cancer Center and serves as the ECOG ACRIN Germline Genomics Committee Chair and Breast Cancer Translational Science Co-Chair. He is the founding director of the IU Health Precision Genomics Program, which has performed comprehensive genomic mapping on over 12,000 advanced cancer patients with intent to direct personalized therapy options. This program has served as a blueprint for several other successful precision medicine programs across the United States. He was named as the inaugural member of the prestigious Komen Scientific Advisory Council and led a multi-institutional project with the support of a Susan G. Komen Promise Award. This work included comprehensive genomic evaluation across 3 randomized phase 3 adjuvant breast cancer trials for which he made several sentinel observations. He uncovered a higher likelihood of therapy-associated side effects for patients of African descent and found that inherited genetic differences might further refine risk for one of the most clinically important toxicities, taxane-induced peripheral neuropathy. This work led to the development and conduct of EAZ-171, one of the first NCI cooperative group trials to focus Acril on Black patients with breast cancer with the goal of overcoming disparities by personalizing therapy in the curative setting. EAZ 171 found that personalization of therapy minimizes toxicity and dose reductions. He has also led one of the first post-neoadjuvant trials for patients with high-risk triple-negative breast cancer to test a personalized approach using next-generation sequencing versus the treatment of physician's choice, showing ctDNA status as one of the most significant predictors of outcome in this high-risk curative setting. Without further ado, I'd like to introduce Brian Schneider.
All right. Well, thank you, Megan and Gina, for having me. And as you could see from the bio, much of the work that I do and am passionate about has been supported by Susan G. Komen. So really grateful for their contributions in helping us, I think, move the needle a bit. So I'm going to try to share my slides with you here. Let's see. And hopefully everyone can see this. I'm going to talk today about a topic that I have great passion for, which is therapy-induced neuropathy. This won't focus entirely on patients with metastatic breast cancer, but I think many lessons here can be shared across the spectrum of patients with cancer at different parts of their journey. So I always like to kind of start reflecting a bit with this slide, recognizing that cancer therapy has a lot of side effects. And as someone who is a medical oncologist and uses these drugs on a daily basis, I think sometimes I get a bit comfortable with the idea that some of the therapies I use have a pretty narrow margin between helping a patient and causing real harm. And I think that's important for us to step back and reflect on. Many of my friends or family who have had cancer often will tell me they're as worried about some of the side effects as they are the disease itself. And I think that's because many of the therapies that we use, which can be incredibly important and impactful in a good way, can also damage organs, and they can cause side effects that range from annoying to life-threatening. And so we'll spend a little time today thinking about that portion of the risk to benefit ratio. Now, for level setting, many of you probably have heard of neuropathy. For those who haven't, neuropathy, which can be caused by therapy and is a really common side effect, typically affects the sensory nerve. So you'll feel often symptoms in the hands and feet. We call it the stocking glove distribution. Often patients will tell me it feels like they've been out in the snow too long, where it may burn, tingle, sting, be painful. It can also, though, affect the motor neurons, which means it can actually cause weakness, which is much less common, but it can do that. And it can also affect the autonomic nervous system, which controls some things that are harder to detect. So things like feeling dizzy when you stand up, or even controlling the bowel and bladder. Now, it is obvious, I think, from this description and for those who have faced this, that neuropathy can impact substantially someone's quality of life, which is really, really important. In addition to that, though, as I'll show you, in some situations, it can also impact survival in a bad way. And it's because it can limit the dose of the very medications that were built to kind of combat the cancer. Now, this is an important intersection and connection, because in the early 2000s, there was a handful of drugs coming out where it actually seemed to be beneficial to have side effects. So there were these drugs called EGFR inhibitors, and for patients that got acne from it, they seemed to do better. There were some hints that for patients who received anti-angiogenic drugs, if you got high blood pressure from the drug, you actually may do better. In this case, the intersection's the wrong way. If you get the side effect, you don't get any benefit from it. You actually probably have an adverse impact on how well the medications can work. Now, I'm going to show this because I think this, to me, is one of the best references and documents that cover what we know about neuropathy to date. This was the ASCO guidelines published in the JCO now about 5 years ago. I was fortunate enough to be one of the co-authors on this publication, which really looked at all the literature out there in terms of thinking about treating and preventing neuropathy. And what I loved about this exercise is if you look at the co-authors, it's an amazing mix of diverse thinkers, ranging from people in the basic laboratories to translational physicians to clinical trialists, patient advocates, and really had, I think, a great mixture. And I'm just going to read the recommendations here because I think truly at the end of the day, I could stop the talk after this because this is what we know today with a few updates. The identified data reconfirm no agents are recommended for the prevention of chemotherapy-induced peripheral neuropathy. Okay. Now, at that time, acetyl L-carnitine was really big, and so we specifically said we should not be considering this. Further, we recommended clinicians should assess the appropriate of delaying the dose, reducing the dose, substituting, or stopping chemotherapy in those who get hurt by it. And then finally, duloxetine is the only agent that has shown appropriate evidence in its use for patients who have established painful neuropathy. There are some limits to its benefit, though. And so this really, I think, in the year 2020, set the stage for what we definitively knew and what we didn't. So I'm going to kind of piece through some of this together, and then I'll move through some data that we did and help create that focused on a very, I think, important and narrow area of neuropathy. So as we think about ways to effectively treat chemotherapy-induced neuropathy, the only drug, as mentioned, that has shown benefit in a randomized prospective trial is duloxetine, also known as Cymbalta. This was published by Ellen Smith back in 2013 in JAMA. Now, what's important to note in this study, it reduced pain, okay? That does not mean for patients where their major symptom was simply, I can't feel my hands and feet. This is not something that's going to help recover sensation. And that's something I think even a lot of treating oncologists forget about. So if a patient says, I have neuropathy, they'll often reflexively think about duloxetine. But if it's not pain or symptoms that you can feel, the duloxetine probably won't help. Now, there's some other exciting technologies that are being studied. This is not ready for prime time yet, but things like scrambler technology is under trial. So scrambler technology is simply inputting electrical currents into the hands and feet with the idea of trying to confuse the nerves and thus ultimately do away with the neuropathy. Now, moving from treating chemo-induced neuropathy to thinking about preventing or minimizing, or at the very least, not worsening neuropathy. As mentioned, there are no preventive drugs today. So if your oncologist talks to you about one, I would certainly question it. Again, pointing out, I do think there are a expanding buffet of options for patients in all settings now. And so certainly thinking strategically about those maybe at high risk or those who already have neuropathy, thinking about picking drugs where maybe that is not the greatest or the highest toxicity. Also optimizing supportive care. Now I give this talk or a similar talk to this to physicians where I really plea with them to talk to their patients about side effects so they can do a better job of personalizing their therapy. But I think this is a good opportunity too to think about also you talking to your provider about the idea of dose reductions or break and really being open with them about things that are bothering you. Because I think that provides the best back and forth in terms of getting out of it what you want to get out of it. I'm going to briefly talk about the role of exercise in prevention. And then finally, one that has, I think, emerged and become a very hot topic, which is, no pun intended, cold or compression during chemotherapy infusions. And I'm going to start with the data on this. Now, this was presented by Karen Jordan at ASCO this year. This is a summary of 10 of the bigger trials looking at cryotherapy for taxane-induced chemotherapy. And the idea of cryotherapy is essentially making the hands and feet cold during the infusion of chemotherapy with the goal of it preventing from you ultimately getting neuropathy. Now, on the right-hand side, you can see the yellow hands or the yellow thumbs pointing to the side reflect trials that didn't show a significant benefit. The green thumbs up are trials that showed, yes, doing this actually does help prevent neuropathy. And the red thumbs down were trials that did not show any benefit. So you can see a little bit of mixture, but certainly several clinical trials showing some benefit. And this mixture is also reflected in the expert guidelines. So if you look here at 2020, ASCO felt the data was not sufficient to recommend cryotherapy as a standard of care. The European guidelines from ESMO said you can consider cryotherapy. And if you look at the most recent version of the NCCN guidelines, or this one at least is from April, if you look at the very bottom bullet point here, it does mention consider cryotherapy of hands and feet to decrease the risk of peripheral neuropathy when receiving taxane therapies. So this is probably the most, I think, high impact publication in this area. This is literally from a couple of months ago in JAMA Oncology. It's called the POLAR study. In this study, they took the dominant hand of each patient and either cooled it or compressed it. Again, the idea here of just putting it in a cold bucket or a cold glove or using a tight pair of gloves to compress. All the patients were receiving taxane for cancer. And what they found is that both seemed to work. So for cooling, the rates of neuropathy fell from 50% to 29%, and this was significant. And for compression, the rates fell from 38 to 24%. So very, very exciting. But this data at ASCO was not quite as compelling. This is data presented at the oral session by Dr. Takano and colleagues from the Cecilia study. So this was a multi-center, double-blind, randomized controlled trial. It was really well done. It was 150 patients with breast cancer who were planning to receive Taxol. Now here they randomized patients to two arms, an experimental group where you really cooled the hands down here to 13 degrees Celsius. For me, I use Fahrenheit, so I converted this to Fahrenheit, 55 degrees. The control was a little chilly, but not cold at 77 degrees. And for reference, of course, we know that body temperature is about 98 degrees. So you can see here kind of a chilling and then a real cold effect. Now, they were very precise in how they did this. They used an orthopedic device infused into the gloves and kind of socks of every patient, where they were able to then use thermometers to prove they were getting down to the exact temperature they wanted to. So very, very precise, unlike many of the other studies. So the primary endpoint was looking at neuropathy that would interfere with activities of daily living at the end of the Taxol infusion. And you see here there was no benefit of going super cold versus chilly, okay? Now, some of their secondary endpoints, one included what was the likelihood of having this degree of neuropathy at 3 months after Taxol. And interestingly and surprisingly, the barely chilly did significantly better than the cold. When they looked at kind of physician adjudicated neuropathy, they saw no difference. And using that same classification, but from a patient perspective, no difference. So I think in total, we would call this a negative trial showing no real benefit. My kind of conclusions from this is, well, from this study, cooling may not work, or it may be that this precise degree of cooling is actually really important. Now, I would say as we think about the biology of cooling the hands and feet, I would say there's no biologic reason to think it should be worse. So I feel pretty comfortable saying that. But I do think our future trials, and we do need more trials in this area, may need to consider the exact temperature we're trying to get down to, the design, and the optimal endpoint. Should we be thinking about neuropathy at the end of Taxol, at the end of 3 months, at the end of 3 years, and what kind of grading system is going to be most impactful as it relates to someone's quality of life? My conclusion from all of this is there's inadequate data to incontrovertibly support cooling as the standard of care, meaning I don't think I should tell a patient you have to do this or you really should do this. I also think that many of these data sets did not address the impact of compression, which is simpler. But I will tell you, I do discuss this with all of my patients, both options. And if they ask me, would I do this? I would certainly do it because I think there are some evidence that it is helpful. Now I'll move now from compression and cooling to the idea of exercise. And this is a really evolving and I think really empowering and honestly just a very cool area. There are now multiple positive studies, most of these are in breast cancer, that have shown structured exercise can actually help prevent or minimize the onset of neuropathy. Now, these are not published in incredibly high impact journals, but these are pretty well done studies, and none of these here have been negative studies. I also think, why not? We know that exercise can impact metabolism, skeletal muscle health, bone health, immunity, cognition. And I also think it's just kind of a neat way to do things together. And this is a picture of me and my two sons. They've gotten much bigger since this picture, but we've kind of used exercise as a way to bond and try to be kind of a healthy way as a family to do something that I think and hope is fairly productive. And there's really, I think, now momentum in this area. For many of you, you probably have seen this article published in one of the highest impact journals, the New England Journal of Medicine, looking at structured exercise after adjuvant chemotherapy for colon cancer, where it actually improved overall survival. So an incredibly big win for exercise, I think, in every way. Now, I want to move to the idea of personalization and tell a little bit of the story of our group and our contribution to the world of neuropathy, and one that may not apply to everyone, but I hope becomes a blueprint for how we can think about asking the question and then ultimately moving the needle in terms of making things better for patients. And to me, the whole idea of personalized medicine is really focusing on thinking about the drug and identifying patients who are going to get all the benefit from the drug and can, at the same time, minimizing side effects or toxicity. So we set out probably over 10 years ago looking at a large adjuvant breast cancer trials, about 5,000 patients getting a standard backbone of chemotherapy with an anti-angiogenic drug. And we wanted to study the blueprint that we are inherited with to see if we could predict what sort of genetic changes might impact the risk of side effects. So here you can see in this bar graph in the light gray is patients of African ancestry, in black is the European ancestry patients, and ancestry became the biggest predictor of side effects. So if you look to the far left, we looked at angiogenic-induced hypertension, markedly higher in patients of African ancestry. On the far right, we looked at anthracycline-induced congestive heart failure, which is a really serious side effect of drugs like doxorubicin or adriamycin, markedly higher again in patients of African ancestry. And right in the middle here, we saw an increase, and I mean a big increase, for taxane-induced peripheral neuropathy, both grade 2 and above and grade 3 and above. For reference, grade 2 neuropathy means difficulty with activities like tennis or golf. Grade 3 and above neuropathy is difficulty with activities of daily living. So this is brushing your teeth or combing your hair. And here you see over a doubling of risk and almost 20% of the patients experiencing this really significant degree of neuropathy. Now, coming back to the idea of intersecting quality of life with survival, these are the survival curves from this 5,000 patient study. And what you can see here is the proportion without disease on the y-axis. On the x-axis, you see time in months as you go left to right. The blue and gold lines represent patients of European ancestry who did and didn't get dose reductions, and you see no difference in survival. The black line represents patients of African ancestry who did not get dose reductions. They do identically well in terms of curability. The red line, and where you see all of the decrease in survival, are patients of African ancestry who had to have dose reductions because of neuropathy. So here again, that intersection of not just an impact on quality of life, but we're seeing a marked reduction in survival. Now, we also believe that we can use our inherited blueprint to understand who's going to be prone to side effects. Remembering that everybody on this call today shares a blueprint, or their DNA code is about 99.9% identical. That 0.1% difference that makes us have different color eyes and different heights can also impact how we metabolize and get rid of drugs. And so two people can walk around with no neuropathy, but if you expose one to a drug, they do fine. You expose the next person to the very same dose and drug, because of that genetic differences, they now have a devastating side effect. And indeed, with neuropathy, we found two genes that we felt to be important. One is called FKMR, which I'll get back to. Another one's called SBF2. Now, this was all interesting science, right? But what we really wondered was, does it matter? So, do patients actually care whether we can predict side effects? And I will tell you, my former mentor challenged me on this and said, I think most decisions are driven by how effective a drug is, and not much attention is paid to how much side effects there are. So, I collaborated with the Research Advocacy Network. Many of you may know Elder Rayleigh and Mary Lou Smith. They're wonderful collaborators with this work. And we set out to formally test whether biomarkers that would predict a risk of a side effect might actually alter how a patient would choose her drug. So we here interviewed about 400 breast cancer patients who had prior chemotherapy, and using a couple of important methods sorted that out. On the bottom here, you see a shared preference. Now, the shared preference is on the y-axis. So the green represents adriamycin-based therapy, where you have no risk of neuropathy, but a small risk of heart failure. The blue represents a taxane, like Taxotere, where you have a moderate risk of neuropathy and no risk of heart failure. Now, on the x-axis, we see the risk predicted of getting neuropathy based on our biomarker, okay? So if you have a 10% risk of neuropathy, nobody wants heart failure. So 80% would say, no, I'm going to take the taxane. However, if we predict a 60% likelihood of neuropathy, it flips completely. Now 80% would say, I will take a slightly less effective drug with a small risk of heart failure because I don't want neuropathy. And so this flipping matched perfectly with our biomarkers. And this really, I think, spoke to me in two ways. One, it did suggest to me that side effects do matter to patients, and that if I want to be an effective oncologist who really does good shared decision making with my patients, I have to be able to both talk about side effects and really effectively explain what they're like so a patient can make the best decision in her treatment. Now, in addition to race and genetics, which I've shown you, the taxane type also influences the risk of neuropathy. So this is from an old study called E1199, where we looked at a number of different taxanes, including Taxol and Taxotere. What we found, and this was unpublished data, is that indeed, if you look at a white population, there's a 3 or 4% increased risk of neuropathy for weekly paclitaxel over docetaxel. But there are other side effects of docetaxel, like lowered blood counts and nail damage and fatigue. So for a largely white population, weekly paclitaxel probably is the better and easier drug. But if you look at the Black population, here you see about a 15% increased risk of neuropathy and markedly more dose reduction. So that what we're seeing here is that based on race or ancestry, a difference in the profile from a risk to benefit ratio standpoint. This work led to this trial. This was mentioned at the beginning, EAZ 171. This was for specifically patients at really high risk of neuropathy, here specifically African American or Black women receiving a taxane, here receiving either paclitaxel or docetaxel. Our primary objective was to see if we could prospectively validate our biomarkers to predict who gets neuropathy, with two key secondary endpoints. One of those was looking at the rates of neuropathy between paclitaxel and docetaxel, and the second was looking at dose reductions between paclitaxel and docetaxel. Now, again, this was the first NCI cooperative group study to focus accrual on a Black population or a population at increased risk for the side effect. And this was really effective, again, because of our collaboration with our patient advocate partners. Here we work closely with Pink Forever in the Indianapolis area with Lisa Hayes and Nadia Miller, who really, I think, worked with us during the inception of this trial and help us build really, I think, good teaching tools and an effective photo bank that really, I think, help with recruitment and really partner not just with us here in Indianapolis, but across the entire US. And I think really was a testament to the success of this clinical trial, despite it being a non-therapeutic study in the middle of the COVID pandemic. We did in this trial validate a high risk of neuropathy. It was about 35%. When looking at our genetic biomarker predictor, we found that the high-risk category had a 38% chance of neuropathy. This is exactly the number we predicted based on our preliminary data. The low-risk category, though, was a bit higher at 26%. So this 12% absolute difference did not quite reach statistical significance for this population sample size. We did find, though, that there was markedly more grade 2 neuropathy, so again, interfering with activities, and significantly more grade 3 neuropathy, which is interfering with activities of daily living. And this was true whether it was judged by the physician who was writing down the likelihood of neuropathy, or from a patient perspective using patient-reported outcomes. We found almost identical findings. Importantly, as I mentioned before, having to reduce the dosage from side effects matters. So here we found significantly less dose reductions due to neuropathy from docetaxel. And importantly, if you look at all dose reductions, again, significantly less dose reductions due to from the patients receiving docetaxel. So our conclusions from this study were there were numerically higher rates of neuropathy with our high-risk genotype, but did not quite reach statistical significance. Every 3-week docetaxel had less grade 2 neuropathy, less dose reductions compared to weekly paclitaxel. And our conclusion then was every 3-week docetaxel may be a better taxane option in Black patients where neuropathy is more common, severe, and impacts survival. And we were very excited. In January of this year, it became formally introduced into the NCCN guidelines for consideration when choosing specific therapy. Now, our next steps are, has this actually moved the needle? And this is work being led by Tara Ballinger from Indiana University and Kimberly Lee from Penn. The first question is, what is the uptake? How has it changed before versus after our trial? The second is, number one, have physicians and patients heard of these data? And if they have and haven't used it, why not? Is there insufficient data from their perspective? Is it just a practice pattern situation or other things? And we hope to survey to inform our next steps, both looking at this from the provider standpoint and also the patient standpoint, using many of our friends and channels to best understand this. But I think there are more work to do, because I think that when we think about neuropathy, it's a complicated side effect. And because of that, I think there are a number of variables or attributes that probably influences the risk of neuropathy. These include some of our clinical factors, some of our social factors, ancestry, genetics, and so on. So I'm going to come back to the genetics. And we didn't have adequate sample size in EAZ 171 to show statistical significance. So we decided to combine the data set of EAZ 171 with that trial I showed you before, E50-103, where here we were able to combine the two. And in the E50-103 trial, we specifically looked at patients of African ancestry. So here we didn't look at just one genetic variant. We looked at all of the common ones. So here on this plot, you see millions of dots. So each of these dots represents a genetic variant. And I'm sorry, this is my only, I think, major nerdy slide, but this is really one of my favorite sort of figures. It's called a Manhattan plot, where here again, you see the entire genome, and the dots toward the top represent those with the highest statistical power, and those that reach the red line are statistically significant. These are called Manhattan plots because they're supposed to look like the Manhattan skyline. So here you learn a lot, and our top variant that reached statistical significance indeed was in the one we had predicted in FKM-R. It appears to be a variant that actually protects from neuropathy, and it's very common in European ancestry at over 55%, and less common in patients of African ancestry at only 15%. So this may be one of the important reasons it matters. But we wanted to look at a variety of different factors in EAZ 171. So as you can see here, this dotted line represents increasing or decreasing the risk of neuropathy. So if you're below the dotted line, it actually decreases the risk of neuropathy. If you're above the dotted line, it increases the risk. So starting left to right, here we know that docetaxel protects. So when we're thinking about tailoring our therapy selection is an important one. We found that body mass index greater than 40, which is morbid obesity, increases the risk of neuropathy. So it begs the question, can we think differently about drug dosing or maybe even the acute effects, as I showed you before, of exercise? It may impact metabolism, glycemic control, etc. Next is poor emotional well-being appears to increase the risk of neuropathy. So begging the question, can we simply do a better job with counseling and antidepressants to nullify this effect? Poor functional status appears to increase the risk. So here the idea of prehabilitation, doing physical therapy to get patients' functional status better. The next one is interesting, but was highly significant. Being never married, significantly protected from neuropathy. Now, I have, as do my friends, a number of potential hypotheses. I'm not sure how to counsel on this one, but interesting nonetheless. And to the right of the dotted line, as I've shown you now, the genetic variant FKAM-R appears to be protective. So this begs the question, can we use this genetic information to think about ways of building drugs to help actually prevent or treat neuropathy a bit better? And this brings us to some of the work we're doing with our Susan G. Komen Scholars Grant, something I'm really excited about. I have an incredibly talented group in my laboratory here at Indiana University. They're actually able to take white blood cells from patients. So a little blood stick, they take white blood cells and are able to turn those white blood cells into little miniature neurons that we can put in a petri dish. And these little neurons actually act like real nerves. They conduct electricity, they have the little neurite outgrowth, so they function just like a nerve. This is really important because when we want to do studies, patients aren't very happy if I want to pull out one of their nerves to study them. That is painful and it can cause serious impact on quality of life. So this gives us the ability to actually study the nervous system in a test tube or in a petri dish. So what we did from EAZ 171 is we drew a tube of blood from each of the patients. And remember, in that trial, I know who got neuropathy and who didn't. So I can take basically and build a little avatar in the petri dish of that patient. And we can sprinkle Taxol in the petri dish to kind of mimic what's happening in the patient. And by looking at this, we can see differences in a number of things like gene expression, methylation. And again, these may provide some major insight into the mechanisms behind what causes neuropathy, with the end goal of, can we build a better drug to help prevent or treat neuropathy? And kind of my last slide here is where we want to move, and that is taking this same sort of blueprint and really moving this to other drugs and other settings like the metastatic setting. So here, in collaboration with a number of investigators across the US, we're hoping to leverage our precision genomics programs. So many of us have programs at cancer centers that take patients with advanced cancer and we map out the blueprint of their tumor. We also can map out their blueprint that is inherited, so we can again understand genetic changes. In this program, we are mapping patient-reported outcomes, so patients on their iPhones are sending in side effects that they have, and then we can learn a lot about them over time with a variety of drugs. So here you can envision in this gray box any given side effect. Let's focus again on neuropathy. It's probably caused by a lot of things: social determinants of health, differences in clinical demographics, differences in prior therapies, differences in our inherited background. And then we can, using sophisticated mathematics, really start to understand which of these is causing the biggest problem for different drugs in different settings, which allows us to think about designing interventions to help do away with it. And this is a beautiful place also to think about using artificial intelligence, where it may be able to pick up patterns that is difficult to do with our own human brains. So we're really excited about this, and we're hopeful we can make an impact in a number of different settings. So with that, again, would like to thank Susan G. Komen for supporting the work that we do. And thank you for inviting me today to talk about a topic that I have great passion for and hope we can make a difference in. So I will stop there and turn it over to you guys.
Thank you so much, Dr. Schneider. Yeah, that was excellent and so informative. I have quite a few questions from our group here. Are you ready to hear them?
Fire away.
Okay, so first question, how common do women experience sciatica type nerve pain while on aromatase inhibitors?
Yeah, so the answer is I don't know. It's interesting. I was a first year fellow the year the ATAC study came out looking at anastrozole. And I remember being in San Antonio for that presentation. It was all over the billboards in San Antonio, Texas. It was on all the buses. And it was a big deal because it was the first time we had an endocrine therapy that wasn't tamoxifen. And so it was a really cool time. And these are drugs that are clearly super effective. But in the original presentations, there wasn't a lot on this condition we now call AIMS, which is this musculoskeletal syndrome where we're seeing muscle pain, we're seeing tendinopathies, we're seeing compression of nerves. And so my former mentor, David Flockhart, who was an amazing pharmacokinetics and pharmacogenomics hero, he discovered, in fact, the metabolism of tamoxifen, did some of the sentinel early work with this. So I think the answer is a lot of these symptoms are reasonably common as a cluster. We don't know exactly what causes them. We think it's somewhat related to inflammation, and our treatment for it's highly variable. So the answer is this remains, in my opinion, some of the toughest set of side effects for the aromatase inhibitors for patients to deal with long term.
Thank you. Next question. Patients of African descent with cancer have more side effects. What about the Asian population?
Yeah, it's a great question. We did not have adequate data to analyze that. And in many of the trials done in North America, they're underrepresented by Asian American patients. My laboratory has a number of Native Asians. They have been incredibly interested in this topic. We do rely heavily on many of the trials coming out of Asia to answer some of these questions. But one thing is clear. The rates of side effects are markedly different in Asian populations. So we really do need to think about that as we're talking to a patient of Asian ancestry.
Thank you. What is the research or data on Cymbalta and tamoxifen?
So the data, again, to date for Cymbalta. So Cymbalta, as many of you know, is a good old-fashioned antidepressant. And so it has all of its usual antidepressant effects. To date, the major benefit for Cymbalta has been with painful or burning neuropathy, largely in the taxane and platinum class of drugs. So little information on its impact for some of the tamoxifen-related side effects.
Thank you. What about metastatic breast cancer patients who have Herceptin and Perjeta treatments every 3 weeks and are experiencing neuropathy? How do we balance the continued treatment with the ongoing neuropathy?
Yeah, this is, the art of medicine. So a few things I would say. Having classic neuropathy from Herceptin and Perjeta is extremely rare. So that would be the first thing. And I would implore, your team to really think about other causes. One thing we often do is, and I do the same, by the way, is we blame everything on our therapies because that's the usual cause. But sometimes in our journey and therapy, other stuff happens. You can get a heart attack, you can have a stroke, and maybe completely unrelated. And we do know neuropathy can happen from other medications. It can also happen related to underlying diabetes. So the first thing I would say is make sure that indeed this is one of those situations where the neuropathy is truly from the Herceptin and Perjeta and not from a prior or something else going on concurrently. But then it becomes an incredibly important discussion with your clinician or care provider. What are the risks of me continuing this? What are the potential benefits of me continuing it? What are the potential risk of me stopping it? And then I think making that joint decision may not be one that's perfect, but it will be the best one for you.
Okay, got one last one here. How would this all apply to other cancers in general, where neuropathy happens outside of breast cancer?
Yeah, I don't know is the answer. And certainly, there's a lot of ways to approach this. What we wanted to do, we feel there's a lot of supportive care data out there, but it's very hard to impact how physicians' practice. It's very hard to impact guidelines where you can actually say, this is what we should do. So we decided to be very narrow, but very precise in our approach so that if the conclusion was true, that it would be something immediately impactful. The limitation of that approach, even though it was, I think, successful, is that it doesn't answer a number of other related important questions. So when I actually did a podcast on JCO that accompanied our paper, and Dr. Shannon West, who was the interviewer, asked that very question. She said, I'm a gynecologic oncologist. We use a lot of the same drugs. Is this going to be the same? And I think it certainly makes a lot of rational sense that it should be and could be. I do think some additional studies outside of the areas we talked about are ripe to happen.
Excellent, thank you. I'm going to turn the mic over back to Gina. Thank you.
We have many more questions in the chat. They keep coming in fast and furious. So I'll just ask the next one. Can neuropathy get better or does it continue to worsen?
Yeah, it can get better. And in fact, it depends again on there's so many factors that go into this, as I showed you. Some of it is the duration of your therapy. So often if you continue that same drug, it's probably going to stay the same or get worse. But after stopping it, some patients actually do have a decline in it. It's not always predictable how that will happen, but this is why I do think communication early on with your care provider is important, because you want to assume that what you're dealing with may be what it's going to be forever or worse. So I think having that open discussion doesn't mean you have to stop it or delay it or change it, but just so that your eye is on the potential that this may continue to be a problem or get worse. So, but the short answer to that is indeed, sometimes we do see it get better.
That's great news. Great to hear. So the next one is, one of the common medications given to patients is gabapentin. What's your opinion on that? And what about Lyrica? I'm sorry, I'm probably going to butcher it.
Close. It's Lyrica. That's no. So the short answer is those have been studied and have not shown to be beneficial. The reason those are commonly used is they are used and approved for other forms of neuropathy, like diabetic neuropathy. So, I think it's reasonable for an expert to talk to their patient about these things. I think it's important to disclose the clinical trials have not shown benefit for chemo-specific related neuropathy. But certainly I have seen patients who have responded well to Lyrica or gabapentin. But again, that should be done in correlation with an expert in the area with all of the caveats.
All right, you're getting a lot of questions, Dr. Snyder. So just for the audience, I'm switching from the chat to the actual Q&A. So if we don't get to yours, we will try to send it in a follow-up email. And I apologize, my cat is knocking a bunch of stuff off my counter behind me. So I was treated with Toxetir in 2009 for early stage disease, and then with Taxol in 2019 after recurrence and metastatic disease. I've been receiving Herceptin and Perjeta or biosimilars continuously every 3 weeks to date. I am Caucasian and have moderate neuropathy that seems to be slowly worsening. Are there any studies that look at patients like me with a long-term treatment with H&P?
Yeah, and I always do want to be careful because it's impossible for me to know your full story. So I don't want to give you bad advice. So I'll speak very globally, and I think hopefully catalyze the discussion with your care provider who will know you a lot better. But I certainly use a very similar regimen. It was based off data from a trial called the Cleopatra study that used a taxane with Herceptin Perjeta. And in that study, at some point, we often were able to stop the taxane, especially when neuropathy or other side effects get bad, and then discontinue the Herceptin Perjeta. If also ER positive, we also add in endocrine therapy. Recent results many of you know of from the Patina study, which was super exciting, showing also adding a CDK4/6 inhibitor had an incredibly beneficial outcome. So I think the short answer is I would talk to your physician or care provider about the side effects, and potentially even thinking about pulling back on it, lowering the dose, stopping it, and if ER positive, even thinking about adding some other targeted therapies in.
All right, thank you for that. What can be done to help neuropathy 2 years out of treatment? It always feels like I'm walking on sandpaper.
Yeah, that's tough. And I think this again speaks to the complexity of neuropathy. I think the first thing I would suggest is, again, making sure your care provider knows about it. That might be impactful should you ever need additional therapy, and it might help weigh into the best selection for you so that it doesn't get worse. I do think if not tried already, I do think trying Cymbalta or another agent would be reasonable. Sometimes it can help with that uncomfortable feeling. The downside again of these agents is it doesn't seem to bring sensation back. So you can't expect all of a sudden things to feel normal again. But if it's causing issues with discomfort while you're walking or even sleeping, sometimes those can be a bit helpful.
Thank you. I'm going to combine two questions that we received because they're sort of related. So the first one was, how about topical solutions? Any recommendations? And then someone asked, will magnesium supplements or oils or lotions help with the neuropathy?
Um, so the first one is topical. There was a positive study. This was an older one using a kind of combination of baclofen, I think amitriptyline and ketamine. It was called BAK, B-A-K. And it was a positive study. I did have a patient who was a pharmacist who compounded and wanted to compound that cream for herself or have her colleagues do it. And we tried it. It maybe helped a bit, but it is really, it's a thick cream. It's super expensive. Insurances often won't cover it. And it's a little bit uncomfortable because you're always kind of walking around with soppy hands and feet for it to be effective. So it hasn't been ideal. Certainly, the idea of a topical that would be nice, easy cream to apply and not be sticky and so forth would be fantastic, but not there yet. Magnesium, I think getting to the magnesium question, magnesium seems to help with a lot of things, and certainly it's been looked at in oxaliplatin-induced issues. To date, for taxane-induced neuropathy has not been overly beneficial. Magnesium can help with other things, though, like kind of some muscle tightness and constipation. So there are other benefits to magnesium. I don't think it helps a ton in taxane-induced neuropathy to date.
All right, thank you. Apologies in advance. I'm going to butcher this drug. Extended Abraxane treatment. Can neuropathy get better when that is stopped?
Yeah, so Abraxane is essentially a form of Taxol wrapped in a nanoparticle, and its rates of neuropathy are pretty similar to Taxol. There was some early data suggesting that it was a bit more reversible. Those studies are really hard though because um, the duration of usage is different from patient to patient. And unfortunately, the patients who do better from a disease standpoint have more exposure to it, so have a higher risk of neuropathy. So it's a very difficult aspect to disentangle. But at least some of the data had some inference or maybe a little bit more reversibility with Abraxane as compared to Taxol.
Okay, we're getting very close to our time, so I'll do two more questions, and apologies to our participants if we were unable to get to your questions today. This seems to be a very hot topic, which tells me we need to do some more blogs, some more YouTube videos. We may be reaching out to Dr. Schneider in the future to assist us with that content. Do you recommend physical therapy for CIPN?
I actually love this question. So the answer is yes. And again, a physical therapist isn't going to fix the nerves. And I think so you want to level expectations here. But many of the accompanying physical function issues that we have, I do think, again, exercise, weightlifting, thinking about balance can really help overall well-being and can help prevent falls. So I do think there are definitely situations where physical therapy can help. I also am really excited about the idea of structured exercise in this setting, and definitely some interesting, even inferential data, thinking about things like acupuncture, which may have an evolving role too. So those things I think are very much on the forefront of where we will be thinking in the future.
Okay, great, thank you. And then our last question for you, can neuropathy happen years after chemo?
It can. I would say that is very uncommon. And typically when that happens, not always, because you always will see cases that are surprising. Typically, when that happens, there's other things going on too. So maybe a patient with diabetes where that has worsened, whereas maybe with their diabetes, they wouldn't have experienced neuropathy, but because they had damage from years ago from their chemo, that diabetes is bringing that out. But it is pretty rare in the absence of another inciting effect to have delayed onset neuropathy. So I don't see that very much, fortunately.
Okay, so that was our last audience question, the last one we had time for at the very least. So we will go ahead and wrap this event up for today. We are so thankful for everyone who was able to join us today. I want to express my sincere and extreme gratitude, not only to Dr. Schneider, but also to Megan for moderating. For everyone, today's session was recorded and it will be posted on our landing page very soon. But you can rewatch this session, share it with someone else who couldn't join us at a later date, or you can view any of our previous sessions that you may have missed on our YouTube page. So please help us spread the word about this important content with your friends, your family, your healthcare professionals. And you can visit komen.org/MBC series to sign up for events or for our MBC newsletter to stay informed. We drop those newsletters monthly. Once again, we want to acknowledge our sponsors for the 2025 MBC Impact Series. Because of their generous support, we are able to continue to bring this community together to share important information, resources, and experiences. So thank you to our premier sponsors, AstraZeneca, Merck, and Gilead, and to our signature sponsors, Daiichi Sankyo and Novartis. This series is made possible because of their generosity. Please also help us by completing a survey, which you can find the link to in the chat feature. Feedback from participants is very important to us and helps us identify topics just like this to feature in upcoming episodes. And finally, the next event in the MBC Impact Series will occur on Wednesday, September 17th from 1 p.m. to 2 p.m. Central. This webinar will feature Dr. Adrienne Wax from the Susan F. Smith Center for Women's Cancers at the Dana-Farber Cancer Institute, and she will share her expertise on the latest breakthroughs in research, clinical trials, and treatment strategies shaping HER2-positive cancer care in 2025, and what these advances mean for patients, providers in the future of care. So once again, thank you all for joining us today, and we hope to see you at an event in the future.